Welcome back. The moment you've been waiting for, a deep dive in into the 2022 Kenya Demographic and Health Survey is what we're getting into at the moment. And remember, you can weigh in using the SMS line 22422, #Newsnight. I hope you've had a chance to preview that particular survey. And if not, I'm sure you'll get some insights from my guests. Let me introduce them. From my far right there, we are joined by the Director General, Ministry of Health, Dr. Patrick Amoth. Welcome to the program, Daktari.
Thank you, Aiga.
Right next to him is the Director General of the Kenya National Bureau of Statistics, MacDonald Obudho. Welcome to the program.
Thank you so much.
And last but not least, Dr. Mohamed Sheikh, the Director General at the National Council for Population Development, NCPD. Welcome to the program as well.
Thank you.
Thank you, gentlemen. It's been a busy day, I can imagine, for all of you, so thank you for sparing some time to be here with us. Let's dive straight into that particular report. And Bwana Obudho, I don't know why I assume that you are one of the key owners of this particular survey, so I'll actually start with you before I talk to Dr. Sheikh and Dr. Amoth. We've seen some of the findings of the particular report. One concerns about the country's fertility rate. Another concerns about potential average number of sexual partners, amongst others. Are some of the headlines that have been generated from that report. For those who are asking questions, first help us understand the methodology of this report. How did you come up with these findings?
Well, it's quite a process from the Bureau of Statistics because before we do a survey, we would undertake to come up with a statistical frame. You can imagine now all the villages in the country, which are more than 120,000. And we design the frame in a way that we only get representations of villages, so that whenever we want to do any statistical surveys, then we sample from those ones. So we have moved from over 120,000 enumeration areas to 10,000. And out of the 10,000, we are just picking 1,692 for the case of the Demographic and Health Survey. Then from each one of them, we now sample 25 households, which then make around 40,300 respondents. So for those many respondents, they are broken down again into urban and rural, so that we are able to give our domain of estimation at the national level in terms of urban and rural, then national, after which then we get into the counties and get to see what are the indicators at the county level for those that can be reported at the county level. And so that is one process that we go through. So the whole process is scientific, even how to get to a particular household. There's a probability process that we go through, and then those that shall have been covered for the survey will then represent the whole population. So the process that we took to come up with, to get to a particular household, we now reverse the probability process so that it can now represent the whole population. That means for areas where a cluster is representing larger area, then it will be having a bigger weight than an area, a cluster that is representing fewer villages or enumeration areas.
Okay.
Yes.
I think that helps those of us who are having some questions. Before I hear from Dr. Sheikh, what to you was new or unique or surprising about the data that emerged from the survey? Well,
I was not expecting to see so much of issues on the element of sexual partners. What is now coming out, because that's what we started from. You know, the question was asking about how many partners you've had in your lifetime. And so then that's what is being reported for men as 7.4 as an average, and 2.1 for 2.3
for women.
For women. Now, even in 2014, the same question was posed to respondents, and we had the same sample size of 40,300. What came out of it was that it was 6.8 for men and 2.1 for female. So it's a question that has been there, and you know,
nothing much has changed.
Yes, you're not talking of a situation where how many partners you have now. It is the whole period of time that one has lived. Yeah.
For people aged between, I think, 15?
Between 15 and 49 for females, and 15 to 54 for males.
Okay.
Yeah.
So you wanted to make that clarification?
Yeah, sure.
Thank you for that. Let me, and we might come back to that a bit later on, but let me hear from Dr. Sheikh now. From the perspective of his organization, the National Council for Population Development, what are the main population issues that you are interested in, even as this survey was being conducted, or what are the issues that have come out from the survey?
Thank you, Waiga Maura. From this Kenya Demographic Health Survey, this is a survey that's conducted after every 5 years to assess, the impact of our investment as a government. So from the results that we have received today, we can see there is improvement in our fertility, that we have a reduction in our fertility rates. There is improvement in terms of maternal and child health. There's also reduction in terms of issues to do with stunting and issues to do with child health. So in terms of population issues, I can see that there's a progress as a government in terms of what you call of investment. So we can say that there's really tremendous improvement in terms of the engagement we had in terms of programming of population programs.
On the back of that, and maybe we just clarify this better, the survey seemed to show that fertility levels are actually more on the decline. Is it as a result of family planning initiatives, personal choices? What do you make of that?
I think it's the investment we did in terms of family planning program. Kenya has one of the most robust family planning program in Africa. And it's because of that, I think we have this fertility we are talking about of 3.4, a reduction from 3.9 to 3.4. But Kenyans should not be worried about that. I saw that it's alarming. People are saying it's alarming, that there's a woman having only 4 children. Our target is to have a fertility rate of 2.1. That is what we call the replacement rate. The world fertility rate average today is 2.5. But what we have in Kenya today is 3.4. But our target is to reach at least 2.5. And this is just in tandem with our economic growth and our population growth. So to balance our population growth and our economic growth. So I think this should not worry the citizen who are seeing this as an alarming, what do you call, statistics. Yeah.
And on the back of that, before Dr. Amoth comes in, what do you then see as the implication of the continued decline? Because you say the global target is, globally you say it's 2.1?
2.5.
2.5, and we are at 3 point something. What would be the implication of a continued decline in the country's population growth? What impact will it have on quality of life, for example?
Population, there are 3 factors or 4 factors that affect population. It's about fertility, it's about mobility and mortality, it's about migration. So one of the factors that we look at is about fertility. And fertility is very important because it's the one which determines our population growth. Kenya, when we got independence, our population was around 8 million. Today we're talking about 50 million, a multiplication of, that is about 5 times, population growth. Our projection is in the next 50 years, Kenya will reach 100 million. So we should not be worried about the population growth. In fact, our population will continue to grow because we have a very dynamic population and a youthful population. But the figures of fertility is something to do with our investment in family planning, the program that we started in the 1965. And that program really has yielded program. Kenya is among the countries that is really praised, for having the most important, what you call robust family planning in Africa. Yeah.
Okay, thank you so much for that. Let me bring in Dr. Amoth, who on the back of matters to do with population can now bring in health and your takeaways from the survey and the data that came out from a health perspective. Could you highlight from a Ministry of Health perspective what your assessment is of some of the findings specifically in regards to health?
In regards to health is, of course, our performance as a sector in terms of the investments we have made and also in terms of the impact that the investments have had on the health sector, and also the data that comes out of this is very important for us for policy formulation in line with the Kenya Health Policy 2014-2030 and of course the social sector vision 2030. So some of the key indicators coming out of that, of course, clearly indicates very strong progress in terms of performance of the key indicators in maternal health, child health, specific diseases like HIV, TB, malaria. So basically, the report clearly shows that the investments we have made in the past 5-7 years have had a tremendous impact, and our indicators show that in the reflection of the report today.
Okay, let's talk specifics. Malaria, HIV, tuberculosis, diseases that have plagued this country for a very long time, a major cause of illness and death amongst Kenyans. What did the survey reveal specifically about those 3, for example?
For TB specifically, is this universality in terms of information regarding TB in Kenya. So literally everybody in Kenya knows about TB. And that is because of the efforts that we have made together with the county governments, relevant partners, to be able to bring this information into the public domain. Regarding HIV, HIV prevention is very key and also one of the areas of investment. One of the things that we looked at during this survey, of course, is knowledge of HIV prevention, especially amongst the youth, 15 to 24 years old. And one of the emerging data from this report is the knowledge about HIV in the youthful population is just about 1 in 5 know about HIV prevention. Yet data from KenFIA survey shows that this particular age group is the one that is recording increased HIV cases. So we really need to work on that platform to be able to ensure that the youth have the correct messaging regarding HIV prevention, and then they can be able to have safe practices to protect them. Regarding malaria, use of insecticide-treated mosquito nets is at 54%. Very high rates, especially in malaria endemic lake region and the highland endemic region. And of course, that is a very critical intervention for prevention of malaria at household level and also at community level.
Okay, thank you so much for that. And I have a bit more, but let me hear from Bwana Obudho, coming back to him on this. What did it take to put together a survey like this, or to work on a survey like this? Infrastructure, you know, who provides for it, who pays for it, who are the implementing partners?
First of all, it is a question of the planning and coming up with a budget that works for the whole survey. And so it started from the Bureau of Statistics, just coming up with the basics that are required, after which then we formed the committees. We had 3 levels of committees: the secretariat that is dealing with day-to-day activities, and then we had the technical working committee that was responsible for the technical related issues, and then the steering committee. Now, at the steering committee level, this is where we are dealing with the policies, and we are also dealing with matters related to sourcing for resources. Now, the key thing about is resources, and then we have the the financial resources, then human resource, tools that would require to undertake the activity, and of course the space of time that would be required for the same. And you know, so in terms of funding, we had to bring together the government and then the development partners. So majorly it was funded by the government and development partners. I would say that development partners took the bigger chunk of the funding, but the government gave support in terms of course, financial resources together with personnel, because almost the whole personnel that undertook the survey was coming from the government side.
Okay. Yeah. The last survey, I believe, was conducted 5 years ago.
Sure. Well, it was actually 8 years ago. It was meant to be done every 5 years.
Yes.
But then COVID came in, which interrupted, and then getting the resources that would really fit to undertake the survey, which would give county level estimates, was not very easy. So there was a delay.
Okay.
And so it was done like almost 8 years ago.
Okay.
Yeah.
Okay. What was the impact of the release of that data 8 years ago? What did it change? What did it bring about that we can then understand what we can expect from the release of this data this time round?
Yeah, you see that you know when before 2014, we had the previous one done in 2008-2009, and that time the total fertility rate was 4.6. Yeah. And so what we now got in 2014 was 3.9. So there was that improvement that we noted. And so it means that the policies that the government had put in place to ensure that there is a reduction in total fertility rate was working. So that process continued, and we're already seeing the results of that because it has gone low again. And this is something that we need to continue doing until we get to just what we are calling the replacement level. That is one. In it, we also had the non-communicable diseases that was introduced for the first time, and so elements of cancer came into play. And well, it was more of knowledge rather than getting knowledge rather than doing the testing and treatment. But then it provided Kenyans with information to get to know about issues of cancer, which is becoming an issue, getting to detect it early, having tests regularly so that it is detected much early. Now, that was also a positive thing that occurred. From those total fertility rates, it was also very helpful for us because what we are getting from the DHS, we are able now to inject into the projection of the population, because you do census once every 10 years, and so if you have to wait for another 10 years to get to see what is happening, then the projection that you are carrying forward to that year might not be very accurate, because it is based on a number of assumptions. One of them being that the total fertility rate is constant, which is not the case. So when you get a change 5 years down the line, then it gives you room now to make adjustment of what it should be, and that informs planning.
Okay. Yeah. Thank you so much for that. And Dr. Amoth, Dr. Sheikh, feel free to respond to some of the things MacDonald or Budho is saying, because some of them fall into actual, the specific dockets that you oversee as Director Generals. And coming to you, Dr. Sheikh, some of the things we look at is, of course, when you look back at 2020 and 2021, at the height of the disruption brought about by the COVID-19 pandemic, there was a lot of concern and data that backed that about increased cases of gender-based violence and teen pregnancies as well. Now, do the results of the survey released today corroborate those particular concerns?
So the result that was shared today, we saw teenage pregnancy has reduced from 18% to 15%. Issues of GBV, especially gender-based violence, has also reduced. And this was, a question. The question was asked was, any cases of, GBV for the last 1 year for male and female. And it seems that, during the COVID, as much as, there was a bit of heightened, talk about issue of GBV, the result shows that the result we have is a bit different. And I think this is is because of the the issues that was at that COVID time, because of the the lockdown, and there's a lot of social media coverage, and a lot of issues that was raised through the social media.
The spotlight was
on that time, yeah. So, but generally the data we have today in the KDHS, it shows that issues of teenage pregnancy has gone down from 18% to 15%, but still again, our target is to have a teenage pregnancy of 0. We can see that figures is really still very high, and when you translate into figures of the numbers, that is about 300,000 teenage pregnancy annually in this country. So it's a very high number, and those are just adolescent age between the age of 15 to 19 years. So that's a very high figure. But generally what we can see is that these figures requires further analysis to see whether, there are specific counties probably which were affected during the COVID that really had a heightened what you call issues of GBV, especially the urban setups, because these figures, is coming across the 47 counties.
Dr. Sheikh, and of course, kudos to, for the knowledge and the awareness now that overall teen pregnancies in the country have dropped. But we have certain counties, Samburu, West Pokot, the data shows they still have a long way to go. What immediate measures can the leadership of counties like that and stakeholders there and citizens there take to work together to make sure that the next time a survey like this is conducted, their county does not appear in the top 5 or top 10?
So there's a government initiative, what we call the triple threat. Triple threat is focusing on 3 things: on teenage pregnancy, gender-based violence, and HIV/AIDS. This is a campaign that was initiated by several government agencies, and this is a program that is really on. We feel that, or we think that this program, we program it well, and we start implementing. It can, get us a good result. Issues of teenage pregnancy, when you look at the data, it's more of, the rural teenagers, those who have no education. So I think we need to focus and have strategic programs for those kind of populations, especially like Samburu, where we have 50% of the girls are, who are aged between 15 to 19 years, I said, either are mothers or are pregnant. So it really is a very alarming figures. But the thing is, teenage pregnancy in the country really varies. Teenage pregnancy pregnancy in Kwale is not the same as teenage pregnancy in Turkana or teenage pregnancy in Mandera. The causes are, and the drivers are totally different. Probably one may be cultural, one may be poverty, one may be issues to do with, other factors which are driving. So I think as a government and institutions, we just need to find out what are the specific drivers of teenage pregnancies in specific counties and make them specific interventions. Like in these figures, we were counties like Meru have a high teenage pregnancy. Central part of Kenya really have the lowest teenage pregnancy in the country. So we are asking ourselves, what's happening in Meru and that's not happening in Kirinyaga or in Nyeri? So I think we just need to do further analysis of this data, do county-specific analysis, and ensure then we have a specific county interventions, and then so that in the next 5 years, at least we can have a different data.
Okay, and I'm sure Dr. Moth has something to say on the same, bearing in mind GBV is a violation of basic human rights, and there are numerous health-related effects that come with that. You want to say something?
Yeah.
Okay, go ahead.
Actually, just from where he has left, when you look at the breakdown of in terms of education level for the teenage pregnancies, you realize that majority of them, the higher percentage of those who are getting pregnant at that early age, are people who without proper education. They are primary level. They're having a primary level education, and so there is, as a long-term measure, there is need really to ensure that our kids are in school. That is very, very important because education plays a major role in a number of indicators that we are seeing. The good ones are informed more by the low level of education. The good indicators are informed by high level education, and so we also need to focus on that.
So good indication definitely plays a key role in changing some of those statistics for certain regions. Dr. Moth, I'm sure you have something to say, highlight some of the key findings regarding GBV, which has health implications as well.
Even before I go to GBV, it's just about fresh what my colleague Dr. Sheikh was saying about. I think what also clearly comes out of this report is the resilient health system that we have built. Because part of this data, I think, for about 2.5 years that was collected during the pandemic. And you've seen like the drop in teenage pregnancy. You've seen again the coverage in vaccination or immunization. You've seen the drop in infant mortality rate, under 5 mortality rate, again against a backdrop of very difficult situation in terms of lockdown, various measures we put in place. So that tells you that the health system is fairly resilient to be able to respond. And also now, as a ministry, when we realize that these services were going to be affected, we quickly put in place measures to ensure continuity of services. But to come to GBV, of course, GBV is has serious health implications, including your self-esteem, the physical morbidity that is a consequence of sexual gender-based violence, and of course the mental health issues that come with this. So it's very, very noteworthy to see that progress is being made in that arena, that sexual gender-based violence cases are coming down. And therefore what we need to do is to maintain that trajectory, put into place interventions that can ensure that that momentum is maintained going forward.
Okay, Dr. Moth. And on the same, within that same report, the issue of health insurance, how much does it concern you as a ministry that we had, what, 30%, less than 30% of men or women? I think the numbers were 25%, around 27%.
26 and 27.
26, 27, who had access to medical insurance, NHIF or private. Does that concern you, especially coming on the back of the kind of pandemic we had and we are still dealing with even till?
Yes, that concerns us, and that is why as a ministry you have prioritized achievement of universal health coverage as one of the key pillars of even the Kenya Kwanza government. Insurance coverage of 25% against our target of 85% means we have a lot of obstacles to be able to overcome. But it is still progress, because if you look at the data vis-a-vis what was there in 2014, it was less than 20%. So it is good progress and work that has been done by NHIF together with the ministry and other stakeholders. And what we need to do is to invest more in social health insurance to ensure that those poor people especially can be able to access healthcare services. And therefore, the clarion call for universal health coverage is to ensure that all can be able to access essential health care services without suffering financial hardship. And the best way to be able to do this is through social health insurance.
But Dr. Moth, what this report is basically saying is that tonight, 74% of one gender and 75% of another gender don't have any medical cover. They don't have a lifeline in case anything happened to them. What does that mean for their families? What does that mean for their county, for the country, for even your ministry as you try and secure, the country's health goals? For
us, the total health expenditure, which is estimated about 550 billion. And out-of-pocket expenditure is 20% of that, which comes to about 110 billion.
Wow.
This out-of-pocket expenditure is that one that drives families into
poverty.
And therefore, that is why we are trying to be able to see how we can be able to navigate with NHIF to ensure that we reduce this out-of-pocket expenditure from the current 24% to about 14%. And how are we going to do that? By embracing the concept of social health insurance. We are going to pay, and health is not cheap. And therefore, there are a raft of measures and reforms that are taking place at NHIF to ensure that we can be able to increase this 25 progressively as we aim to attain the goal of 85%. This will require us to be able to tighten our belts because some of us will be required to be able to contribute more because of the concept of risk pooling. What happens now is that the pool is too small, and therefore many people, once they run out of their cover, they have to dip into their pockets and then they get poor. If you have many people into the social health insurance scheme, then you have a big pool, and therefore the young can be able to subsidize the elderly, the healthy can be able to support
those who are unwell.
And that is the main thing that is now we are trying to crack how best to be able to do it.
Okay, thank you so much for that. And I'm sure, Dr. Sheikh, you may have something on the same, but Bwana Obudo, let me first start with you on this one. We're going to finish this up and move on to other things, but the questions keep coming up. Bearing in mind we live in a society where free speech is encouraged, but there are certain questions that usually are more often than not discussed in private and not in public. And so Tom Wolf, who's a known researcher, he does a lot of surveys, has a few questions. He's asking, for example, how certain can we be that all you polled were able to confidently answer questions in regards to sex behavior? And were the interviews in person? Were they on phone? Were they online? And if in person, wouldn't those deemed as quote-unquote promiscuous be shy to respond? How did you tackle that particular aspect of some of the tougher questions within your survey?
Thank you. Actually, Tom Walls knows that we are professionals, and before we get into the survey, there are a number of issues that we take into consideration. If you look at the compositions of the team themselves, we had 3 females in a team and only 1 male within the team. The 3 females were actually covering the survey, were covering the women questionnaire. And this is where most of those questions were. For the male, it was done by 1 because we had just sampled half of the households that were meant for the whole survey. Now, the next thing is to deal with the confidentiality, which is one of our core values as a Kenya National Bureau of Statistics. And this is something that has to be practiced by any research house, that you ensure that confidentiality is maximum. And that's when you will guarantee whoever giving you the information that confidence of speaking to you. So the survey started from listing the household members using the household questionnaire, after which, based on the ages and the sexes, you are able to pull those who are now eligible for the next set of questions. Like females who are 15 to 49, you are able now to single them out. Males who are 15 to 54, you are able to single them out for the next set of interviews. So you move from the household questionnaire to individual questionnaire, say for a woman, yeah, and then you go aside. You are not doing that in public. We were encouraging cases where you go aside. And in fact, when the interviews are ongoing, even the supervisor is not allowed to go check on what is happening because it is meant to be very confidential between the respondent and the interviewer.
Okay.
Yeah, so that gives that element confidentiality.
And I imagine residents of Migori County and Murang'a might have the same concerns as Tom Wolf. The survey showed Migori County leading the number of men with more than 2 sexual sexual partners. Murang'a leading the number of women with more than 2 sexual partners. How can you calm the fears of those from those counties tonight that surely did our people really say these things in your survey?
Simple. Look at the number of people we interviewed. We are talking of over 40,000 respondents, and we are not singling out anybody to have given this kind of question. When we are doing, when we collect the data, as we are now doing the analysis, it is we anonymize the data so that it is not possible to get to know who gave what kind of a response. That is another thing that is very, very important in statistics. And so, for us to really ensure that we get it right, it starts from the respondent, that be as sincere as possible. And this is what we, again, I know if we don't get the right information, then it will be misleading, and therefore will be misleading the country. So we are very conscious of that, because statistical operations are very expensive. We require a lot of resources, you require a lot of time. And so if you go to the field and do not get it right, that will be very unfortunate. And
wasted opportunity.
Yeah, sure. Yeah.
Okay, thank you so much for that. Dr. Sheikh, we carry on, and you can respond to what he said even as you answer this one. Looking at some of the findings from the survey in regards to fertility, antenatal care, delivery care, mortalities, it shows that there are notable or significant variations between counties. Some are performing well, others are performing poorly. What do you then do with this data as NCPD to address these variations so that at some point in the future we have some sort of uniformity, come to the same level of performance?
So from the results, you can see there's total variation as the indicators you have mentioned, from antenatal care, postnatal care, child mortality, infant mortality. You can see like for the fertility, we are talking about 3.4 in average, but there are some counties with a fertility of 7, and more. But the thing is, this is average as a country. This was conducted across the 47 counties. What we're going to do is to do a deep dive of these, figures and this data, and analyze, county specific, and then probably again, set baselines for these counties so that at least we can have interventions, for those specific counties. If you look at antenatal care as a country, I think we have done very well. The antenatal visits are, very encouraging at 98%. Deliveries, skilled deliveries at, 89%, really very encouraging from 66%. But there's some counties, again, when you go for skilled deliveries, they're below even 50%. So these variations really, and these, differentials are really something that we need to tackle. But what we need to do is, what we have are the figures. These are just the numbers that we are saying this is 69% or 89%. But we need to go beyond the numbers. What are the leading, factors of this? Why, if women are not coming for antenatal visits, what is the reason why they're not coming for antenatal visits? So we need to do deep dive and find out the reasons and, the factors that is contributing to these, what you call, variations. And then develop specific programs, interventions for those specific counties. So NCPD will set baselines, will give figures and facts for those counties, and again advise the counties in terms of policy advice. What we do mostly, we analyze this data and prepare what we call papers or advisory briefs.
I was going to ask if you're going to have to do now another survey to find the why behind the...
No. We just analyze, but also we work with academia, with universities in those countries, so that at least they can do now specific, what we call research on specific counties or a specific area. Because the surveys, is huge and expensive, but then you can do research on those specific areas. Now, if it's Samburu with a teenage pregnancy of 50%, we can just do, a county-specific either survey or county-specific research and find out why girls in Samburu are, getting pregnant compared to the others. So as the National Council for Population and Development, we're going to do deep dive in this data, do further analysis, and prepare advisory papers to specific counties and even to the national government.
Okay. On the back of that, let me just jump to Dr. Amoth, who I'm sure has some thoughts on that, even as he tells us how are we doing with our vaccination programs. Are children getting vaccinated? What's the vaccination coverage? And was that interrupted during at the height of the COVID-19 pandemic, when a different vaccine was the priority in the country?
Thanks. I think vaccination was very, the figures that we have in this survey is about 80%, is 80%, which is key for the basic antigens. And that tells you again the resilience of the health system, that the measures that we put in place during the pandemic to ensure continuity of essential healthcare services basically then worked. But if you also look on the flip side, there's also 2% of the Kenyan children who are not vaccinated at all. it is our intention to be able to find out who these children are, where they are, so that we ensure that nobody is left behind. Also, in terms of the previous question that Dr. Sheikh weighed on, is to see the kind of progress that we have made. In fact, in some of the areas like skilled birth attendants, we are at 89%. Our 2030 target, according to the Kenya Health Policy, is 80. So we have achieved our target 8 years before the time.
Okay, that's
so now it's incumbent upon us to ensure that once we achieve that target, then we maintain it and even surpass what we have. So we need to continue making progress on this. And again, coming against the backdrop of the pandemic, we are really surprised at those figures that we are seeing. It shows that the investments that we have made and the work that has gone in the sector regarding maternal and newborn child health has yielded the fruits that we so desired.
Okay. And in a short while, I'll be taking a break because when I come back, I'll have a lot of feedback to read and some viewers have questions which I'll pose to you. But Dr. Amoth, now that we're talking about children, why don't you briefly mention what the survey revealed regarding the nutritional status of our children, infants, young children, and the malnutrition status, and also concerns about sweet beverages and some of these other quote-unquote unhealthy foods that some are giving their children.
Again, in terms of nutrition of children, the survey reveals good progress. The rate of stunting has decreased. The rate of wasting has also decreased. Of course, sweetened beverages and processed food, we've seen increased rate of obesity, which is a challenge for us, and we need to start developing interventions to ensure that we can be able to nip this in the bud. But another strange statistic that came, of course, is a rate of breastfeeding. We stayed at 60% compared to what it was 8 years ago. So we really need to do a deep dive into that and find out why all other indicators regarding maternal and newborn child health have increased, except for breastfeeding. And we need to discuss that and find out what other measures we can be able to put in place, because we know breast milk is the best food for the baby.
Very, very interesting. Thank you. Thank you so much for that. Coming back to you, Bwana McDonald Obudho. So what does the future of this survey then look like? Do you anticipate, and God forbid there be, no pandemic to get in the way again, do you foresee another 5 years that we need to do another survey like this? Or might there be a time when we don't need one, or we could change the timelines just to ensure that there's full value?
Okay.
With all the input that goes into it.
Well, in a very simple way, the only time that we'll stop doing DHS as a country is when we get to the status of a developed country. DHS is meant for developing countries because that's why we have a lot of health issues to deal with. Policies to tweak a bit to get the health systems in the right direction. The next thing is that we should actually not get late as we did last time. We need to remain focused to ensure that it is done every 5 years. Kenya has been very consistent in a number of its surgical operations, which are done on schedule. So this one, we had that interruption, and hoping that there won't be any other interruption, we still need to monitor a number of health-related indicators over time, because we have not reached the goal, and we need to see how we are performing. Whatever interventions that the health providers are putting in place, the stakeholders are putting in place, we need to see, are they working over 5 years? Are they working well? Some of these indicators are not changing within a year or two, so we require a space of time, and that's why we are talking of 5 years, span of 5 years, so that after 5 years we are able to look into what policies that were there, what interventions were put in place to confirm that really they are working or not. Rather, so we do not wait for a much longer time to get to see some of this, because we could be waiting for too long only to realize that we are going off the track. So it is important to keep our DHS regularity on check.
Okay. Good. Thank you so much for that. Let me read two questions opposed to two of you. One to MacDonald Obudho and one to, of course, Dr. Mohamed Sheikh. Someone here wants to know, having glanced at the survey, we see a situation where on the issue of physical violence, teachers came up as a key factor in that. Please explain how that happened and under what circumstances. This is from a concerned viewer this evening, so you can talk to us about that. For Dr. Sheikh, a viewer here is saying, of course, kudos to the good news, population under control and so forth. But they want to know, the economies that are seemingly growing around the world are said to have very high populations. Your India, your China, and so forth. Shouldn't Kenya be seeking to grow our human capital to be able to achieve some of the success that some of these countries are experiencing today? I don't know who will begin. Maybe, Bwana Obudho, we can start with you.
For the case of teachers being so much involved in domestic violence
or physical violence, as per the survey,
violence, I think we need to dig deeper into that, because that has not been done. Remember, what we have given is just the key indicator reports, which are analyzed at another level. The main report will be coming out 3 years down the line.
Oh, is it?
Yeah. So what we're dealing with is actually not the full report. You know, by the time we are getting there,
summary of
we are expecting to have 135 indicators at the national level and 72 indicators at the county level. So what we have just done is a gist of it. Yeah. So the finer details will come out in the next 3 months. And what cannot come out from that, might not come out from that report, then will now require further analysis that Dr. Sheikh has talked about. That we are intending to undertake from his end.
Okay.
Yeah.
As there's a viewer here who also wanted to elaborate on the question of men and women owning land, owning property. I'll come back to you for that. Let me allow Dr. Sheikh to respond to that question by that viewer on population growth. A very controversial topic.
Controversial. I know all these population issues are very controversial, but that's why we're here to clarify on issues of population matter. Our vision in terms of population is to have a quality population. The number does not matter. We can have billions and millions, but the thing is, as a country, what we're saying, we should have a quality population. A population that is educated, that's healthy, that is skilled, and that can compete globally. Right now, when we set our vision 2030, we set an economic, what we call GDP growth of 10% and a population growth of 2.5%, so that the population growth and economic growth are in tandem, so that we don't have a population that is growing faster than our economic growth. But so if you was asking about India and China, which came first? Is it the population growth or the economic growth? Is again another question that we need to be clarified. But as a country, really, what we are saying is that our population growth is really growing in a manner that is really that is in tandem with our economic growth, although we're not doing not so well in our economic growth. But the thing is, it should not be worrying us. The numbers does not matter. Let's focus on the health of our population. Let's focus on the skills of our population. Let's focus on reducing poverty and dependency ratio in our population. So the number does not matter.
Okay, thank you so much for that. Let me pick a question that is directed to us, Dr. Amoth, but either of you can also respond to. When a county is getting SGBV free care to clients to ensure uniformity in access to this medical emergency care, when will all counties have at least a rescue center for difficult cases, for those who need to be away from the perpetrators who are at home? A second question, and maybe Dr. Amoth, and this is sort of off the cuff on this one. Somebody here saying, Dr. Amoth, we saw you quite a bit at the height of the disruption caused by the COVID-19 pandemic. What's the status of the country today in regards to that particular virus? Because recently we heard of cases where at the airport people are being asked to have COVID tests or COVID vaccination. It's being asked again. Where are we in regards to that pandemic? I'll respond to those two questions.
I'll start with the GBV. It is to be able to work with other sectors and also the other players to ensure that we mainstream sexual gender-based violence services at the primary care level at all facilities across the entire country. And that is still work in progress. Of course, we may not be able to achieve our targets in one go, and therefore we will continue to invest in that area, highlight the areas where this challenge is being posed, and of course put in interventions working together with other stakeholders. Regarding COVID-19, I think the status as at now is stable. No need to worry. If you have not been vaccinated, please go and get your vaccine. If you have not gotten your booster, this is the right time to be able to get your booster. The vaccines are safe. They protect you from severe disease and also from death due to COVID-19. We were hesitant to be able to make any interventions based on the data that was coming from China because we want to use our own data to be able to devise our own interventions. And so far as sitting back, I don't think anything has changed since the other jurisdictions made those additional measures they took. That was based on it. But the measures that we need to make must be backed by science. They must not be backed by geopolitics. They must not be backed by whims of individuals. It must be backed by purely by science. And when that particular point comes, then we'll be able to advise the country appropriately.
Do you want to comment on the viewer who asked why the airport is now asking for vaccines or COVID tests, which is something I think that had declined over the last couple of months?
No, that arrangement has never been removed from our advisory. If you're coming into the country, we require you to have a COVID-19 vaccination certificate or proof of vaccination. If not, then you need to have a PCR COVID test taken 72 hours before you arrive in the country.
Okay.
That has never been lifted.
Okay, thank you so much for that particular clarification. Okay, I think on that note, gentlemen, we'll take that short break that I mentioned. When we come back, we'll get some other thoughts on this and feedback from viewers as well. As I mentioned, there's a lot in this report, and I'm told it's kind of like the brief. There's a bigger one coming out in the next, you said 3 years.
3 months, no, 3 months.
3 months, 3 months.
It is from the very same survey.
Okay.
Yeah, so it's only that we needed to give out what Kenyans can start using immediately as we deal with further analysis to give out the bigger report.
Okay.
Yes,
so 3 months from now, a lot more could be made clear, but that's why I have my guests here to help you understand some of the findings from this particular survey that was released earlier today in Nairobi. Let's take a short break. Lots to digest.